This is going to be the cult of OMI, changing the myocardial infarction paradigm one soul at a time. Declarations. I don't have any financial, ethical, moral conflicts of interest to declare. I'll be using several online references for the ECG examples, and some of them are directly quoted in places throughout this particular presentation. And the use of this material is purely for educational purposes, and I will be referencing those resources at the end of this presentation. Learning objectives. Objective 1, define occlusion myocardial infarction, also known as OMI. Differentiate OMI from STEMI, or ST elevation myocardial infarction. Identify the need to use the OMI paradigm, and identify 7 common ECG manifestations of OMI. And I have kind of coined the term the Magnificent 7, or the MAG 7, as a memory aid to think about conceptualizing some of these common findings that are associated with OMI. All right, so before we get too far along, I do want to talk a little bit about what a normal 12-lead ECG should look like, because a big component of this particular presentation will be on interpreting ECG patterns. This is a very important, pattern recognition is actually a very important component for identifying OMI and other things. So when we look at the 12-lead ECG here, you should have positive deflection. The QRS complex should deflect positively in leads 1, 2, and 3, and that indicates that you have normal axis. You see the QRSs are upright, and if we look at the QRS axis here, it's at 54 degrees, and if you remember, lead 1 sits at 0 degrees, and then you've got 90 degrees, and an axis anywhere from 0 to 90 degrees is considered normal, and then up here from 0 to negative 90 degrees is considered left axis deviation, whereas 0 to negative 30 is considered physiological left, and then negative 30 to negative 90 is considered pathological left, and then over here from 90 to 180 is considered right axis deviation, and then right up in here is the right shoulder axis deviation. And this is a quick way of identifying normal axis by looking at leads 1, 2, and 3 and having an upright QRS complex. We should also see negatively deflected QRS complexes in V1. So you see I have a V1 here, and the QRS complex is downward deflecting. I should have normal R wave progression throughout the precordial leads. So your R wave will start off small, and the QRS complexes will deflect negatively. And then as I move from V1 to V2, you will have a biphasic QRS, where half goes above the baseline, half goes down. And then in V3, you should have a positively deflected QRS. And then in V4, the R wave should be even taller and positively deflected. And then V5, and then finally V6, you should actually have a R wave, a QRS that's positively deflected, but the R wave should get shorter. So you should see something like this if this is the ECG baseline. V1 starts off negatively deflected, and then the R wave goes up and then drops back down, kind of like going down and then up a hill. You should have no J-point elevation or depression, and J-point is the point where the QRS complex returns to the baseline and should be preceded by the T wave. And so this point right here is the J-point, and you can see that that J-point is more or less at the baseline here in this particular ECG. And if it elevates above the baseline, we call that J-point elevation or ST elevation. And below the baseline is what we call J-point depression or ST depression. And then we talked about the normal axis already. So that's what we should see with a normal 12-lead ECG. Okay, so classically we conceptualize acute coronary syndromes as falling into one of two major paradigms. And just as a reminder, an acute coronary syndrome is a situation where you have an acute Compromise of a coronary artery. This is typically due to a blood clot or a thrombus that forms suddenly in a coronary artery. This is often due to the rupture of an atherosclerotic plaque. And then you have a marked decrease in blood flow through that coronary artery that causes ischemia, injury, and or infarction in areas distal or areas that are supplied by that coronary artery. And so you're going to get signs and symptoms that suggest an acute coronary syndrome, the classic Levine signs, retrosternal, squeezing, crushing chest pain, diaphoresis, nausea, vomiting. Sometimes you'll have pain that radiates into the jaw and the arm. Some people have pain in the back. Some people present with less common findings such as abdominal pain, generalized weakness, fatigue or malaise, difficulty breathing, decreased activity tolerance, and things of that nature. And these more atypical findings are going to be more common in older patients and people with certain chronic conditions where you can have some neurological deterioration such as diabetes. So you have the signs and symptoms and some risk factors that suggest an acute coronary syndrome, and then you get a 12-lead ECG, and based on the analysis of the 12-lead, we can categorize these patients as either falling into what's known as a STEMI, and to meet STEMI criteria, this is the classic STEMI criteria. You have greater 2 or more millimeters of ST elevation in one lead, or greater than 1 millimeter of ST elevation in 2 or more contiguous leads. And a contiguous lead group is just a group of leads that looks at the same area of the heart. And the classic contiguous lead groups can be conceptualized through the saying, I see all leads, whereas I is the inferior wall, and that includes leads 2, 3, and augmented vector foot, or augmented voltage foot. That's I. C is the septal wall, and this is, we look at this through leads V1 and V2. A is the anterior wall of the left ventricle. All of these are in reference to the left ventricle. So inferior wall of the left ventricle, but just remember that the inferior change also looks at the right side of the heart, so the right ventricle, the SA node, the right atrium, and in right dominant circulation, the posterior wall may also be supplied by the right coronary artery, the RCA, which feeds the right side of the heart, including the inferior wall of the left ventricle. The septal and anterior, V3 and V4, and these tend to go together, V1 through V4, and this is the left anterior descending artery of the left coronary. So you have the left main coronary artery, and then it branches into the LAD, which goes along the front, the anterior septal surface of the heart, and then the circumflex, which goes along the left side of the heart and feeds the lateral wall of the left ventricle. And this is, we look at this through leads 1, augmented vector left, and then V5 and V6, or V5, V6, 1, and AVL. 1 in AVL is often referred to as the high lateral wall. That looks high up or superior on the lateral wall, and then lower on the lateral wall in leads V5 and V6. So if you have STEMI criteria, so you have either more than one, so here's your QRST, and then with the ST elevation, you'll get a J point that elevates above the baseline. If you have greater than 2 millimeters of this in a single lead, or greater than 1 millimeter in 2 or more contiguous leads, then we call that a STEMI, or an ST elevation myocardial infarction. If you don't see that, then these patients will typically fall into what's known as an NSTEMI/USA paradigm. NSTEMI stands for non-ST elevation myocardial infarction. STEMI/USA unstable angina. And traditionally we say if there's a STEMI, these patients are more critical and they need immediate cath lab activation and they need prompt reperfusion therapy. Typically that's going to be percutaneous coronary intervention, PCI, where you do balloon angioplasty followed by the placement of a stent. If, however, they classically would not fall into the STEMI category, rather the InSTEMI/USA category, they would not necessarily need to go to the cath lab right away, and they may end up going to the cath lab 1, 2, maybe even 3 days later, if at all, and rather they will have extended medical management, maybe repeat ECGs, right, P2Y12 inhibitors and glycoprotein inhibitors and monitoring and so on and so forth. All right, so this is the way that we classically conceptualize and we classically look at treating acute coronary syndromes. So what is OMI? So what we have actually found is up to a third, not quite a third, but up to about 30% of patients who have NSTEMI, right? So they are not STEMI patients, so they do not meet STEMI criteria, and so we would traditionally say that they're not as critical, but when up to a 30% of these patients go to the cath lab, they have a total or near total occlusion of the coronary artery. All right. So this is actually really important. And in fact, there are studies that suggest poorer outcomes in the NSTEMI patients compared to STEMI patients. Why is this? Well, we believe it's likely due to delayed care. All right. So up to 30% of these patients have a total or near total coronary artery occlusion, and they may not do as well as STEMI patients. All right. So what this suggests is that there's a large group of patients who we would put in the NSTEMI category that would greatly benefit from going to the cath lab, and in fact, the cath lab may substantially decrease morbidity and mortality in these patients. And there are several findings beyond STEMI criteria that suggest this total or near total occlusion of a coronary artery without adequate collateral circulation. And this is in fact, so total or near total occlusion of a coronary artery without adequate collateral circulation that results in injury and infarction. This is in fact the definition of OMI, Occlusion Myocardial Infarction. All right, and this was originally coined by Dr. Smith et al. In their 2017 writing, the OMI Manifesto. So there are 7 findings that I'm going to talk about. This is not all-inclusive, but these are perhaps easier to conceptualize and to identify when it comes to more novice providers who do not have extensive background in looking at and interpreting multiple 12-lead ECGs. And again, this really comes down to encountering this many times over and developing good pattern recognition. And so I'm going to focus on these 7 findings. I've coined the term the Magnificent 7. Well, not so magnificent if you're the patient that is experiencing one of these. And that includes the following: classical STEMI criteria, okay? Hyperacute T waves, De Winter T waves, posterior myocardial infarction, South African flag sign, subtle ST elevation in inferior leads with subtle reciprocal ST depression in high lateral leads, and positive Smith-modified Sgarbossa criteria in the setting of a left bundle branch block or ventricular paced rhythms. So the new paradigm that is emerging from the analysis of all this evidence really is as follows. Somebody has signs and symptoms of an acute coronary syndrome, and we get a 12-lead ECG, and instead of STEMI in STEMI, it's OMI NOMI. OMI stands for Occlusion Myocardial Infarction, and that includes STEMI. So STEMI is actually a type of OMI. All right. Hyperacute T waves is another type of OMI. De Winter T waves is another type of OMI. Posterior MI, South African flag sign, subtle ST elevation with reciprocal depression, positive Sgarbossa criteria. So instead of just STEMI necessitating immediate cath lab activation, all of these necessitate that with signs and symptoms, right? So we are capturing more of that 30% of the in-STEMI population that ends up having a near total or total occlusion of a coronary artery. Now, if they don't necessarily fall into these paradigms, they may fall into something called the NOMI, or a non-occlusion myocardial infarction, and we would treat these very similar to the in-STEMI, where they may have urgent or delayed cath lab activation with medical management and additional workup, such as cardiac enzymes and serial 12-lead ECGs. All right, so let's just review classical STEMI criteria, because this is a type of OMI. So again, 1 or more millimeter of ST elevation in 2 or more contiguous leads, or 2 millimeters or more ST elevation in a single lead. So over here on the left, we see a fairly classic example of an anterior is STEMI. So you can see that this is the QRS complex right here, looking at V2, and the J point is right here, where the QRS complex changes, the deflection changes, and you go into the T wave, and you can see that that it is elevated well above baseline. This is sometimes called a tombstone, which is something that is a type of morphology that is going to be more common when you get ST elevation in the precordial leads. So you've got this elevation here in V2, V3, V4, and even a little bit extending into V5 and V6 and 1 here. So this is an anterior lateral STEMI with extension in, well, yeah, really it's an anterior lateral STEMI, or it's an anteroseptal STEMI with lateral wall extension. So this, again, is a pretty bad problem. This suggests occlusion of the left anterior descending artery, or even in this case, because the lateral wall is taking a hit, this may even be very proximal. This may be a proximal left coronary artery occlusion here. Now over here on the right, we see a more classical STEMI manifestation in the inferior wall. So you have leads 2, 3, and AVF. Remember, 2, 3, and AVF are the inferior wall. That's the right coronary artery. And you see that you've got the QRS complex, and you see you've got the J point here, and you've got several millimeters of ST elevation in 2, 3 AVF. And you do have some reciprocal depression in 1 in AVL. We'll talk about reciprocal changes a little later on in this presentation and what they can potentially mean. So this is a very classic STEMI presentation for an inferior wall. And so these are 2 common findings when it comes to pretty straightforward STEMI criteria. Okay. So nothing changes there. STEMI is still considered an OMI, and it still needs to go to the cath lab immediately. But let's talk about hyperacute T waves. What are hyperacute T waves? Well, hyperacute T waves are T waves that are large and out of proportion to the QRS complex. So you should have some proportionality, right? So if you have a QRS complex, the T wave should be proportional to the QRS complex, kind of the area under the curve, and the size. Even though the T waves are going to be flatter and generally not as tall as the QRS complexes, just the kind of the area under the curve, if you will, is going to be similar to the QRS complex. And when these T waves get very large and out of proportion, to the QRS complex. All right, I'm exaggerating that a little bit, but you have a very large T wave here. That is a problem. And generally speaking, greater than 5 millimeters in the limb leads or greater than 10 millimeters in the precordial leads is a general rule of thumb to help us identify these. These tend to be wide and broad and not as peaked or pointy. All right, so a tall, peaked or pointy T wave that looks like this is called a tented P wave. All right, that does not suggest a hyperacute T wave, but rather that suggests an elevation in serum potassium levels or hyperkalemia. This is a classic finding in hyperkalemia, and I'm going to show you some examples here in just a bit. So this is what the classic hyperacute T waves look like. Now in this case, not only do we have these tall, broad, look how wide this T wave is in comparison to the QRS complex. It's huge, way out of proportion. But not only do you have hyperacute T waves, but if you see right here, this is about where the J point is, you have very obvious ST elevation here. So just based on the ST elevation alone, you would call this an OMI, but I just wanted to show you what these hyperacute T waves can look like. So they're broad, so they tend to be wide. Okay, they're tall, they're very large in comparison to the QRS complexes, and they are symmetrical. They generally look the same on the upward side and the downward side. There's symmetry to them. All right, but there are other findings that can cause large peaked T waves. One of the major things that can do it is something called benign early repolarization, which we see right here. Benign early repolarization generally has notching at the J point. So if you look right here, I've got this little notch, right, where you have some negative deflection as you're going into your J point. So you do have a tall, broad T wave, but you've got this notching here, and that tends to suggest benign early repolarization over a hyperacute T wave. Now, on the right-hand side, we have a tall, peak, tented T wave, right? So you've got this tenting going on here, all right? And this suggests hyperkalemia, whereas here you have a very wide, okay, a very wide and symmetrical T wave that isn't quite as pointed at the top as this T wave on the right here. So this is more what a hyperacute T wave looks like compared to benign early repolarization and hyperkalemia. All right, just a quick case study. So we got a 45-year-old male presents with sudden onset chest pain. It resolves after the administration of nitroglycerin and aspirin. Here is the initial 12 lead that we see. So what do we have here? Well, I've got 1, 2, and 3. So already we notice that 1 and 2 are upward deflected, 3 is downward deflected. That suggests left axis deviation. So we got a little bit of axis deviation here. V1 is still down. If I look at V1, V2 is biphasic, V3 goes up, V4 goes down. So our R wave progression is a little abnormal as well. So there are some subtle abnormalities, but the J point, looking at the J point, I don't see substantial J point elevation or depression. And so I don't see a whole lot of anything. It does look like the T waves are maybe a little wide in some leads, and that might be something. Let's see. So 5 minutes later, his pain returns and another 12 lead is obtained. There are some ST changes here. So we notice that the ST segment in the precordial leads, okay, actually the J point is just a little depressed, right? So the J point is actually below the baseline. So we've got some ST depression, and we've got some T wave anomalies, but this does not meet STEMI criteria, right? So no STEMI here. So this does not meet STEMI criteria. So the cath lab is not activated, and instead we give additional doses of nitroglycerin as well as some fentanyl for the ongoing pain. The patient is then delivered to the emergency room, and the physician suspects an NSTEMI and orders cardiac enzymes be drawn, and then they got to go to the lab, and then we're going to wait for cardiac enzymes to get back. 90 minutes later, the patient now develops bilateral crackles in the lungs and hemodynamic instability. So the blood pressure is unstable. The cardiac enzymes are back, and there is a markedly elevated troponin. The patient is finally sent to the cath lab, where they find a 100% occluded left anterior descending artery with TEMI zero flow. And TEMI is just a way that blood flow distal to some disease in a coronary artery is measured, and that stands for thrombolysis and myocardial infarction. And there's actually a pivotal study out of the late 80s, early 90s called TEMI-3 that looked at reperfusion therapy in the setting of myocardial infarction. But the way that this works is TEMI blood flow. The best blood flow is TEMI grade 3. That's where you shoot contrast and you look at the contrast, and the contrast penetrates through the coronary arteries and into the distal parts of the coronary arteries, and it does so rapidly. And then you've got TEMI 2, you've got TEMI 1, and then TEMI 0 is where essentially you have an occlusion. You shoot the contrast goes up to the occlusion, and then there's no more contrast. So you don't see any contrast absorbing X-rays past that, and that is indicating that there is no blood flow. There is no distal blood flow, no collateral blood flow. So following PCI, the patient remains unstable and in cardiogenic shock. He requires Impella to be placed to support hemodynamics, and he requires inotropic support. He is eventually discharged from the hospital with 30% left ventricular ejection fraction and congestive heart failure. And if you remember, right, your left ventricular ejection fraction should be double that, right around 60% or so. So he's essentially lost about half of his cardiac function. And the question is, could that have been avoided had we gotten him to the cath lab sooner, and instead of waiting over an hour and a half, when we got that second ECG, actually identified the presence of those hyperacute T waves, and recognizing that this was an OMI, even though it did not meet STEMI criteria, it was still an OMI and still needed to go to the cath lab immediately. Maybe we could have presented this poor outcome and this substantial morbidity in this patient. So this is just another comparison of hyperacute T waves versus hyperkalemia. So here we have those hyperacute T waves in the precordial leads specifically. All right. Remember, these are wide, they're broad. And then if we look at the T waves here with hyperkalemia, we see the T waves are very tall and they are very pointy. You have this classic tenting signature to them. This is called tenting. All right, and you can see that these do look a little different from the hyperacute T waves associated with OMI. Again, you kind of have to look at lots of these and really get a feel for the pattern recognition. Although I will say that hyperkalemia is a great imitator, and you always want to have a high index of suspicion for hyperkalemia. So if there is some history that suggests hyperkalemia and you see T-wave anomalies, you want to be very aggressive at treating this if you suspect it, right? So if this is someone who's had severe burns, crush injuries, electrical injuries, rhabdomyolysis, acute kidney injury, has a history of chronic renal disease or chronic renal failure, or end-stage renal disease, and has missed dialysis, something on the lines of that, you'd want to strongly think about hyperkalemia. All right, moving on. So the next thing I want to talk about is something called a De Winter T wave. And De Winter T waves, I want you to think of De Winter T waves as a kind of, a De Winter T wave is a kind of, think of this as a kind of hyperacute T wave. So this is just a variation. It is a type of hyperacute T wave. So what happens with De Winter T waves is you get tall, prominent, symmetrical T waves in the precordial leads. All right, that is very important. Your run-of-the-mill hyperacute T waves can occur anywhere, but these are going to be in the precordial leads. All right, so V1 through V6. And what you're going to get is you're going to get an upsloping ST segment depression. All right, so we look at V3 here. Here is the baseline. Here's the J point. So you see how the J point is depressed. So I have ST depression, first of all. And you have what's called upsloping depression. All right, so there's basically downsloping depression, and then you have what's called horizontal depression, where it looks horizontal before you go into the T wave, and then you've got this upsloping depression. And it is this upsloping depression right here that is classic to De Winter T waves. So you've got large, wide, broad, tall T waves in comparison to the QRS, plus this upsloping ST depression. And when you see that, that is strongly suggesting that you are having an NOMI that tends to impact the left anterior descending artery. You can get a reciprocal ST segment elevation that is very subtle, that is generally less than a millimeter, so half a millimeter, 1 millimeter in AVR. So typically we don't use AVR diagnostically, but ST elevation in AVR in the presence of other conditions can be very concerning, and this is one of those conditions that if you get some subtle ST elevation in AVR and then you have abnormal precordial T waves, that should push you to think about De Winter T waves or hyperacute T waves. The typical STEMI morphology may precede or follow the De Winter pattern. So you may get ST elevation, and then that ST elevation changes to De Winter T waves, or you can get De Winter T waves that then transition to ST elevation. So these changes can be very dynamic, particularly if you have a very unstable plaque that's rupturing and causing little clots, and then those little clots are being dissolved or they're moving to other areas. You can have lots of dynamic changes, and that can be very concerning. So again, think of De Winter T waves as a kind of hyperacute T wave. Here is a 12-lead ECG demonstrating De Winter T waves. So again, we're going to be looking at the precordial leads specifically. All right, and you see that you've got this upsloping ST depression, particularly here in V2, V3, V4, and even in V5 and a little bit in V6. And then you've got broad, tall, symmetrical T waves that are large in comparison to the QRS complexes. And then if you look over here in AVR, look at this. You've got some elevation in AVR. So all the signs are there. This is not an NSTEMI, right? This is not NSTEMI. This is OMI. This is likely an occluded left anterior descending artery, and this patient needs to go to the cath lab. All right, let's talk about posterior myocardial infarction. So the problem with posterior MI is that the posterior wall is not directly visualized on the 12 lead. right? Because it's the back of the heart. And when you put a 12 lead, when you put your precordial leads on, they all look mainly at the front of the heart from right to left. The front of the heart, the anterior septal wall, is reciprocal or opposite to the posterior wall. And this is critical to understanding how we can detect the presence of a posterior MI. So when you see ST depression in leads V1 through V3, this is highly suggestive of posterior MI, because what can happen is if you have ST elevation in one lead, the lead that is opposite to that, okay, you will often get ST depression. And that's what reciprocal means, right? And so if you're looking at, let's say, V1 here, okay, so this is the front of the heart, that depression may be reciprocal to elevation in the back of the heart. That's what we're saying. So ST depression in V1 through V4 should mandate something called posterior leads, V7, V8, and V9. And essentially what you do is you take leads V4, V5, and V6, and then you put them on the back of the patient to get a view of the posterior wall. And I'll show you how to do that. And this is also something that can help. The ST depression that you see tends to be horizontal as opposed to the upsloping depression that you see in De Winter T waves. So, if we look at V2 here, do you see how we have depression of the ST segment or the J point, and see how this is horizontal down here? So that's that classic horizontal. Now, another thing that you can do is you can take the 12-lead ECG, if you see this depression in the precordial leads V1 through V4, flip the ECG around, so flip it around, rotate it, and then kind of pretend like you're looking at it in a mirror. And when you do that, if it looks like the classic ST elevation, that is called the mirror criteria, and that's a quick down and dirty way of pointing you in the direction of a posterior MI. But remember, you're going to be seeing this depression in the precordial leads, specifically V1 through V3. So, if you get an ECG and you see ST depression in V1, V2, V3, and sometimes it'll even extend into V4, but V1 through V3 are most reciprocal to the posterior wall. And I will say that a posterior wall MI is often associated with an inferior wall MI. So you can see that we have some elevation here in leads 2, a little bit in lead 3, and a little bit in AVF. So we actually have an inferior STEMI, but in about 80% of the population, the right coronary artery actually feeds the posterior descending artery, and the PDA is what supplies a lot of the posterior wall blood flow. And so you can see a posterior MI in conjunction with an inferior MI. And you can also see posterior MIs that are by themselves or isolated. It's not as common, but it does happen. So if you see this, what do? Well, you take V4, V5, and V6, and you put electrodes on the patient's back. So this is on the left side. And what you're going to want to do is you're going to want to plant an electrode. You're going to find the spine. All right, and then just lateral to the spine, underneath the scapula here, you're going to put an electrode, and then right underneath the tip of the scapula, you're going to put, so just inferior to the tip of the scapula, you're going to put another electrode, and then you're going to go lateral to that and put another electrode, and then you're going to take V4, the cable for V4, and attach it to this electrode here, and then the cable for V5 and attach it to this electrode here, and then the cable for V6 and attach it to the electrode that is next to the spine, and then you'll hit the ECG button and you will record the ECG again, and then when that new ECG prints out, you'll circle V4, V5, and V6, and then just write 7, 8, and 9 to let everybody know that this is a posterior ECG that you just formed. And then you will look at that, and so that's what we did here, and you see that you've got elevation here in V7, V8, and V9, and that seals or clinches the diagnosis of a posterior wall myocardial infarction. All right. The next finding is something referred to as South African flag sign. And this is just a way of helping you remember this. So the South African flag has this green Y in it. And that green Y, if you imagine placing this on top of an ECG, that green Y, so your standard ECG printout, at least here in the United States, starts at lead 1, right here. All right, 2, 3, all right, and then you have AVR, and then AVL, and AVF here, and then you have V1, V2, and V3, and V4, V5, V6, but that's not relevant. And so anywhere, any lead that is in this green arrow, and that includes leads 1, 3, AVL, and V2, are the leads that are impacted by this particular finding. All right. So you superimpose this on top of the 12 lead, and if you see subtle, and in the case of a myocardial infarction, subtle just means does not meet STEMI criteria, so that's ST elevation or ST depression that is less than 1 millimeter. That's what we mean by subtle. So this could be either subtle or pronounced, and pronounced would be greater than 1 millimeter. So you're going to have subtle ST elevation in lead 1, subtle ST elevation in lead AVL. All right. As well as possible ST elevation in V2 and ST depression in lead 3. All right. So ST elevation in 1, AVL, and V2, and ST depression in lead 3. And this is characteristic when you have a blockage of the first diagonal artery that comes off of the LAD. And so you've got the LAD that comes down, then you've got D1, D2, D3, the diagonal arteries, and then you've got your septal arteries, S1, S2, etc. So it is this first diagonal artery that comes off of the LAD, and this is important because this feeds the high lateral wall. So we often say that the circumflex artery feeds the lateral wall, which is true, but the highest part of the lateral wall is fed by the D1 artery that comes off of the LAD. And when that D1 artery gets blocked and it produces a high lateral wall MI, you will get or can get this so-called South African flag sign. All right, so I've taken ECG, I've superimposed. So again, ST elevation can be subtle or pronounced in lead 1, ST elevation in AVL, and ST elevation in V2, with ST depression in 3. So let's go ahead and take the flag away. All right, so we take a look at lead 1. You've got some elevation there in lead 1. So ST elevation in 1. If we look at AVL, we've got ST elevation in AVL. If we look at V2 here, you've got just a little bit, very subtle, It's not contiguous. It's not considered classically contiguous, so V2 would not be contiguous with 1 or AVL, but it's still there nonetheless. And then if we look at lead 3, you can see the inverted depressed T waves, right? And again, this is that classic, let me move this up here. There we go. So this is that classic South African flag. Let me get rid of that green. There we go. So if I draw the green arrow on the South African flag, you can see that those 4 leads are the ones that are impacted. All right. So let's look at subtle ST elevation with reciprocal depression. All right. So this is somebody who has ST elevation that does not meet STEMI criteria. And so we said that the anterior septal wall is reciprocal to the posterior wall, right? So the posterior aspect of the heart is reciprocal to V1, V2, and V3. Well, another area where you have opposites is in the inferior and the high lateral, or rather are in the inferior and high lateral walls. So the inferior leads to 3 and AVF are reciprocal to the high lateral AVL and 1, or 1 and AVL. So if we look at this ECG here, you notice I have some very subtle ST elevation here in lead 2. Does not meet STEMI criteria though. If you look at 3, very subtle ST elevation in lead 3, and the same here in AVF, right? So this would not meet STEMI criteria. So you could not call this a myocardial infarction if you used the STEMI paradigm. So I've got ST elevation in 2-3 AVF, but it does not meet STEMI criteria. And then I have, if I look at 1 in AVL here, you see that I have depression in 1 in AVL. This is a powerful finding. Reciprocal changes are powerful and suggest infarction. And in addition to that, I have one more thing. This is not always going to be present, but if it is present, it is even more powerful, right? I have ST elevation in AVR, which doesn't look at any specific wall of the heart, but it is associated with badness in the setting of other ST abnormalities, right? So, even though STEMI criteria is not met, this is an MI. This needs to go to the cath lab. This is likely an inferior wall MI. It just does not meet STEMI criteria, but it is still an MI. It is an OMI. All right, well, what about left bundle branch blocks and ventricular paced rhythms, right? Well, unfortunately, left bundle branch blocks and ventricular paced rhythms tend to cause ST aberrations. And with signs and symptoms of acute coronary syndrome, we often state if somebody presents with a left bundle branch block, a new left bundle branch block, or a presumably new left bundle branch block, maybe they should just go to the cath lab, right? Well, here's the thing. Are there any tools that might help us better categorize patients with left bundle branch block and ventricular paced rhythms, right? What about pre-hospital implications, right? Where we don't necessarily even have an old ECG we can pull or a prior ECG that we can compare. Are there any tools that can help push us in one direction or another? There absolutely are. And it really comes down to something known as discordance. So, because ventricular depolarization is abnormal, repolarization should also be abnormal. So, if you have a left bundle branch block or a ventricular paced rhythm, all right, and the QRS complex goes up, the ST segment should go down. So the ST segment should move in the opposite direction of the QRS complex. This is called discordance. And a certain amount of discordance should be seen in the setting of left bundle branch block and ventricular paced rhythms. This is known as appropriate discordance. All right, and based on this idea, a set of rules can be used to analyze a rhythm for evidence of OMI. And the current rules that most people are using are what are known as the Smith-modified Sgarbossa criteria. So this is originally developed by Dr. Sgarbossa, and then it was further modified by Dr. Smith a little more recently. So the criteria include the following. Do you have concordant ST elevation greater than 1 millimeter in one or more leads? Right? So normally, right, if your QRS complex goes up, right, the T wave should go down, right? They should be discordant. But what say you have a left bundle branch block or ventricular paced rhythm, and the ST segment moves in the same direction as the QRS complex. That is known as concordance. This is abnormal. You should not see concordance. All right, so if you have concordant ST elevation, that's a problem. If you have concordant ST depression greater than 1 millimeter in one or more lead, specifically looking at leads V1 through V3, that is a problem. And then proportionately excessive discordant ST elevation in greater than one lead anywhere with greater than 1 millimeter of ST elevation. All right, and this is defined by greater than 25% the depth of the preceding S wave, and I'll show you how we can look at that. So what is this saying here? Well, this is saying that there is discordance. So the ST elevation is discordant, but the extent of the ST elevation measures 25% or more the length of the S wave. So essentially what happens here is you have massive concordant ST elevation, right? That's really what we're talking about. So let's just take a look at some examples to better wrap our mind on this. All right, so here is an ECG of a patient with a bundle branch block, and specifically a left bundle branch block. And so you can see that you have a wide QRS complex, right? You've got P waves, so this is a sinus rhythm. So a sinus rhythm with a wide QRS complex might be a bundle branch block, and then we can easily look at lead V1 and do what's called the turn signal criteria. So if you have a wide QRS complex and it deflects downward, think of that as like a turn signal. If you want to turn to the left, turn your car to the left, you will pull your turn signal down. And if the QRS deflects upright, right, and you want to turn right, you would flick your turn signal up. And so that would indicate a right bundle branch block, and downward would indicate a left bundle branch block. And so you can see these wide downward deflected QRSs in V1, and that is diagnostic for a left bundle branch block. So what we have here is in AVL, I have ST elevation here, and that ST elevation moves in the same direction as the QRS. So the QRS is moving up, and the ST elevation is moving up. This is concordant ST elevation. This is abnormal. This is a problem. This may very well be an occlusion myocardial infarction and not what we would expect to see in the setting of a run-of-the-mill left bundle branch block. All right. So here is concordant ST depression in a ventricular paced rhythm. So we've got, it looks like 2 pacer spikes, so maybe like some AV sequential pacing. But again, the QRS complex is pointing downwards, it's deflected downward, and the ST segment is going downward. So I have concordant ST depression here. So remember, concordant ST elevation and concordant ST depression are problematic. I also have some ST depression that is concordant here in lead V4 and even in V5. Right? So this is problematic, and this is not at all what you would expect to find with a ventricular paced rhythm. You would expect to find something more like this, where the QRS is going down and the T wave is going up, right? You have discordance, but I have a loss of appropriate discordance here, here, and here. All right, now let's talk about excessive discordance. So if we look at this ECG here, you see the QRS complex is wide, it's deflected downwards, so that's a left bundle branch block. So you would expect ST elevation, and so far everything looks okay, right? The QRSs are pointing down, the T waves are pointing up, everything looks discordant. Okay, fair enough. Well, let's take a look at this. So what we're going to do is we're going to zoom in, and specifically we're going to zoom in on leads V1 and V2 here. And that is what we've done in this picture right here. So the J point is at the red line in V2. So here's the J point right here. So I've got elevation right here, right? That's what this is. Between this red line and blue line is ST elevation, right? And if I measure this, I've got 10 little boxes or 10 millimeters. So I have 10 millimeters of ST elevation. Then what I'm going to do is I'm going to look at the S wave, right? So here is the QRS complex pointing downwards, right? And from here to here is a preceding S wave, right? So this is the S wave, and I'm going to count the number of boxes, and that in this case, so I've got 10 millimeters of ST elevation here, and I've got 37 millimeters. The S wave is 37 millimeters long, right? And so 10 divided by 37 equals 0.27 or 27%. So the ST elevation exceeds 25% of the preceding S wave, meaning this ECG has excessive discordance. Right? Let's take a look at this ECG here. Right? You can see that the machine interprets this as left axis deviation, which is true. 1 is up, 2 and 3 are downwards. And you've got negative 55 here on the QRS axis. That's pathological left axis deviation. The QRS complexes are wide, and if you look at V1, it deflects downward, so we turn signal it. That's a left bundle branch block, but that's all the ECG, the interpretation, the algorithm that the monitor is using, that's all it says. It says normal sinus rhythm, LAD, left bundle branch block. But what do we notice here? Look at right here in V3 specifically. What do we see? I have got excessively discordant ST elevation, right? So here's the J point way up here. There's the baseline. So this is the ST segment. And just eyeballing it, the ST segment is probably about half of the length of the preceding S wave, right? So it's like up near 50%. All right. So that's the last of the Magnificent Seven, but I do want to just speak about an honorable mention. This is not traditionally an OMI, but it is critical, and it is actually associated with severe stenosis of the left anterior descending artery and a very high risk of becoming an OMI. And this is something called Wellen syndrome. It presents with two types. They're either biphasic or deeply inverted T waves, and specifically we look at leads V2 and V3 for this. And history is key here. So the key history in Wellen syndrome is you'll have a patient that has a prior anginal episode that has resolved. So the patient had some pain, and now the pain is resolved, but they have these biphasic ST segments or T waves or deep inverted T waves in V2 and V3, even though they are not having pain anymore. So your patient will typically present pain-free, but have a recent history of chest pain. Think of Wellen syndrome as an incomplete MI. So essentially what happened here was you had a plaque rupture, a clot formed, but then the clot dissolved or broke up enough to where you're now getting blood flow through that area and you have reperfusion. So it's an incomplete MI, all right? So there was an acute occlusion in the LAD that caused initial chest pain, but it was only transient and the pain resolved. However, a critically stenosed LAD is left behind, and this places the patient at an incredibly high risk for having an anterior wall MI. Medical management of these patients is typically not as successful and typically not going to be appropriate because these patients are going to be at such high risk of having an MI that they do not respond as well to medical management. And so they really should have PCI or CABG or some other acceptable reperfusion therapy occur very quickly. So here are the two major types of Wellen syndrome. This is Wellen's type A. This is where you have the biphasic T waves. So part of the T wave is above the baseline here, right? And then it dips down below the baseline. So it kind of looks like this, right? A biphasic T wave. And you see that in both V2 and V3. Whereas Wellen's type B, you have these deep inverted T waves in leads V2 and V3. So these are both Wellen syndrome. I believe that Wellen's type B is more common than Wellen's type A, but these are both Wellen syndrome. And again, remember that this is going to have a history of chest pain that has resolved, and they still have these ECG findings left over. All right, and then this is just demonstrating that you can have a Wellen's-like pattern in other leads, even though Wellen's is classically thought of as occurring in V1 and V2. You can see this occur in some other leads, right? So here you have some interesting findings. You have some ST elevation in leads 2, leads 3, and AVF. So you have ST elevation, but you also have these deeply inverted T waves, right? So you actually have a STEMI. You have someone who's having a STEMI, but it is actually breaking up and it is resolving in front of your eyes, and you are actually getting reperfusion occurring, right? So very interesting that you can see these dynamic changes in other situations. So I just kind of wanted to demonstrate that or show you there. There are also tall T waves in the precordial leads, and you might be tempted to call these hyperacute T waves or De Winter T waves. But these are likely, particularly this depression, is likely reciprocal changes to ST elevation or a STEMI in the inferior wall. Because remember, in about 80% of patients, the inferior wall perfuses the PDA, right, or supplies the PDA, which perfuses the posterior wall. So this is actually more likely a reciprocal change to elevation in the posterior leads, and in fact, that's what's going on with this patient. This is actually an infraposterior OMI that's occurring. And this patient had a thrombotic lesion in their right coronary artery, and they had that right dominant circulation. So this is an infraposterior MI that was experiencing some reperfusion. All right, what about NOMI? Well, here's what a NOMI would look like. All right, so you've got someone with signs and symptoms of acute coronary syndrome. You've got ST depression and multiple leads, as you see here, right? So we've got a little depression here in AVF, maybe a little bit in 2 here. All right, so I got a little bit of ST depression. Maybe just a tad bit here in V5. Maybe a tad bit over here. All right, so just some very subtle ST depression, but it's not really reciprocal to anything. All right, so it's not reciprocal to elevation in any other leads because we don't really have any elevation. We do have some elevation in AVR, but it's just by itself there. Maybe just a tad bit of elevation here in V1, but it does not meet any criteria. So you've got some subtle elevation in the precordial leads in AVL, doesn't meet STEMI criteria. Elevation in AVR is certainly concerning for advanced coronary artery disease. So this is certainly somebody that has coronary artery disease likely, right? They're not healthy, but they're not having an active OMI. That's the point, right? So this is still a problem, but this is someone who does not necessarily need to immediately go to the cath lab, right, and have that 90-minute door-to-balloon time. So this is more what an OMI would look like, or a NOMI rather. In this case, this is not an OMI. This is a NOMI, right? Don't forget about mimics. There are many things that can mimic OMI and NOMI. I won't talk about them in detail in this presentation, but just to name a few: benign early repolarization, pericarditis and myocarditis, myocardial contusions, Wolff-Parkinson's-White disorder, elevated intracranial pressure can cause massively inverted deep T waves, hypothermia can cause Osborn waves that impact the ST segment. Brugada syndrome, which is a genetic disorder, sodium channelopathy that can cause ST changes. Many drug and electrolyte effects can impact the ST segment, such as sodium channel blocker toxicity. It actually looks a lot like Brugada syndrome. Digoxin effect, hyperkalemia, left ventricular aneurysms, and even left ventricular hypertrophy can cause ST changes. All right, and then here are some of the publications that I'm referencing. The American College of Cardiology 2022 STEMI Equivalent Guidelines. This is an important paper that was published in October of 2022, where the American College of Cardiology does not use the term OMI, but rather what they say is there are multiple findings that should be considered equivalent to a STEMI. Okay, so they use the term STEMI equivalent as opposed to OMI, but they're really talking about the same thing. They're really fundamentally talking about the same thing. All right. And this was published back in October 2022. So there is a big shift even in mainstream medical organizations toward the recognition that there are many other things that need to go to the cath lab in addition to STEMI. All right. Here's a study talking about patients not meeting STEMI guidelines that still benefit from reperfusion therapy. Here are some of the landmark trials that were done in the late 1980s into the late 1990s. Jesse 1 was the landmark trial that established fibrinolytic therapy. It was completed and published in 1987. And then you have TEMI 3B, Gusto. You've got the OMI Manifesto. You've got the difficult study. This is the study where they found that up to about 30% of patients that were diagnosed with STEMI ended up having a completely occluded or near completely occluded coronary artery when they went to the cath lab. Here's another study looking at NOMI versus STEMI ECG findings. And then these are some of the references where I got some of my images. All right, so in conclusion, the standard STEMI paradigm can result in missing large numbers of patients who are experiencing a significant occlusion that results in injury and infarction. These patients are better identified using the NOMI paradigm as opposed to STEMI versus NSTEMI. And 7 common manifestations of NOMI include STEMI, hyperacute T waves, De Winter T waves, posterior MI, South African flag sign, subtle ST elevation with reciprocal depression, and positive modified Smith-Sgarbossa criteria in the setting of a left bundle branch block or ventricular paced rhythm. Thank you all so much, and I hope you enjoyed this presentation.